Kia ora. We have made it to the last day of the COVID-19 Masterclass. I'm Jackie Hedingham, manager of the Otago Global Health Institute, OGHI for short. Today's webinar will run for approximately an hour. We'll finish at around 1 p.m. New Zealand time. Our webinars are being recorded and will be available on the OGHI website later. We are also live streaming through the OGHI Facebook page. During the webinars, our speakers will do their presentations and you can ask questions at any time using the Q&A function at the bottom of your screen. I will then read the questions aloud for the speakers to respond. Our first presenter this morning, Associate Professor Patricia Priest, is head of the Department of Preventive and Social Medicine at the University of Otago. Her research interests include infectious disease epidemiology and prevention and control, screening and public health and epidemiology. She will discuss what is New Zealand's strategy for surveillance of COVID-19 going forward. Patricia.
Okay, cool. Right, kia ora koutou. Thanks, Jackie. And this is the title of the talk that I was asked to give in the series, What is the New Zealand strategy for surveillance of COVID-19 going forward? And I just want to start with a brief caveat, which is to say that I feel slightly ambivalent about being part of a masterclass series. I am a public health medicine specialist and an infectious disease epidemiologist, but like many people involved in the response to this pandemic, I'm not an expert on coronaviruses per se, or indeed on responding to pandemics in general. I've been trying to help out with the expertise that I do have and am a member of the Ministry of Health's Technical Advisory Group. It's been a really exciting learning curve for me being involved in this pandemic response. But although surveillance is a key epidemiological component of the pandemic response, obviously, surveillance per se is not the focus of my research. So I'm not actually here to present either research that I have done or operational work that I have done. And I can't speak for the ministry, which is the body that runs the surveillance. So I'm here to share with you what is being done based on what is publicly available from the ministry. So just wanted to be clear about that at the beginning. So just to start, I'm not going to start by reiterating how we got here, because I'm sure you're all very clear about all of that at the moment. But just to remind us what surveillance is, it's essentially information for action. And it has this series of steps, which of course are not completely differentiated and happen more or less all at once, but it's a process where the aim is to get analysed and interpreted data to the people who need to take action in a timely fashion. And we do surveillance not just in pandemics and not just for infectious diseases even, but we do surveillance for lots of different diseases all the time. And in New Zealand we include notifiable occupational diseases, and we have a cancer register and so on. So it's quite a broad thing, surveillance in general. And my introductory epidemiology textbook says that these are the purposes of surveillance, and you can see that all of these pertain to the pandemic response. It's probably not often in New Zealand we find ourselves doing surveillance to support disease elimination, although the measles surveillance is one of those times. But for the pandemic, as you know, we've chosen to follow an elimination strategy, and it has these 4 pillars: border controls, robust case detection and surveillance, contact tracing, and kind of community control measures. And so the surveillance in this list is surveillance where you're looking for cases, and that's what I'm going to focus on today. Obviously, one could carry out surveillance as in systematic data collection and analysis around what's happening at the border, around contact tracing, and I know you've seen some of that earlier on in the series. and around whether people are doing the things that we hope that they are in terms of control measures in the community. But I'm going to talk mainly about the case surveillance today. So you've seen this graph several times already if you've been watching the series, and this comes from this ministry webpage where they tell us how many tests have been done on a daily basis. And you can see that they've gone up and down over time. And I've just added in these red lines, or possibly orange lines, which tell you when at least some of the changes in case definition for testing happened. So it's really just to make the point that, as President Trump is very well aware, is that you find when you look, and we have changed our strategy for looking over time to adapt to things like the capacity to do testing and also the particular concerns at the time. So initially our criteria for testing were quite narrow and focused very much on people who had travelled or were linked to known cases. Then over time we spread the net more widely because we were wanting to find out if there was transmission out there in the community that we hadn't otherwise picked up. And then more recently we have gone back to a slightly more focused approach. And so the ministry recently released a document which outlines the national testing strategy for the next few months, well, from last month and this month and next month, which has these goals which you'll recognise if you've ever looked at our influenza pandemic plan of continuing to keep the virus out of our communities, but also to ensure that if it does get there, that we're able to shut down those chains of transmission and stamp it out. So we've moved away from sort of large-scale-ish asymptomatic testing of people who don't have symptoms. We're very much focusing on the border because that's where our biggest risk is at the moment, but wanting to ensure that if we do have some infection in the community, we pick it up as early as we can. And so we're using this kind of risk-based approach where we're explicitly trying to think where are the key areas of risk for infection. And one of the important things there is actually limiting the impact of our testing and all that goes with that on people's access to healthcare for other conditions. So there's a lot of concern, quite rightly, about the delayed care and people seeking care for other conditions during the alert level 4 and so on. And we need to be doing testing in a way that doesn't overwhelm our lab facilities and our clinical facilities. So we want to get the best bang for our buck without preventing people getting the care they need for other things. The strategy document, which is at this link here, has this table which explains what it's trying to do. And I'm going to talk a bit about these 4 parts of the supporting activities. Just to note that there's these objectives which are, so we want to find cases as soon as we can because we really want to stop any chains of transmission getting going. We need to keep a weather eye on whether there might be clusters or chains out there that we've missed. This high-level crisis management, this is kind of about the environment and context in which the testing strategy operates, which is making sure that we're keeping an eye more broadly internationally and on the research data so that if we learn something new that would change our strategy, we do that. And underpinning everything ought to be the need for equitable access to testing in order to provide equity in the outcomes as well. So our testing strategy is mainly about, is mainly clinical, so picking people up who might need to be treated, and about control, trying to find chains of transmission and shut them down, rather than sort of surveillance in its broader sense, because at the moment we believe that we don't have disease in the community to be surveilling, as it were. So just running through those 4 parts, The first part about testing people with symptoms. So I said we're being a bit more focused, and we've continued to have the same symptom definitions we've had for some time, but we've linked it to, or it's been linked to, this higher index of suspicion. So this is not the testing at the border. This is testing people who have symptoms. And of all the people who might have symptoms, it's trying to say who are the most at risk of having been infected with COVID. And so people who've been in contact with a case, people who've travelled or been in contact with a traveller, and people who've worked internationally on vessels of various kinds. And these people are to be tested and should self-isolate while they wait for the results, because they are the people we think, if anyone has it, it might be in that group. We still don't think they're at very high risk, but it's being cautious. And those tests are notified to the medical officer of health, the fact that people have met this definition. And that enables the testing to be tracked, so that the ministry can keep an eye on whether this testing appears to be being available equitably, whether there seem to be some groups or areas that are missing out, in which case they can put in place some processes to try and address that. There is still testing of people with symptoms who don't meet the higher index of suspicion. It's on advice from a clinician. And so those people, this is kind of edging into keeping an eye out in the places where we don't really think we'll find COVID, but just giving ourselves the chance of finding it maybe if it's out there. So we don't really think those people have COVID, but they might not meet the higher index of suspicion, but the clinician might feel that it's worth testing them because maybe there's some slightly less, don't quite meet those criteria, but they're concerned that they might actually have it, and so they can be tested, but they don't need to be self-isolated. The testing data is still reported and again analysed to ensure that there's testings being equitably available. And the document also notes that there might need to be some more active approaches to making testing available to people who may have experienced barriers to accessing primary care, where this testing is mainly now happening. Part 2 is about contact tracing, and this is the first couple of points there are just to point out that when a case arises, we want to not only try to find the people that they might have infected, which is what we tend to think of as contact tracing, but we also want to try and find out who infected them, because if we can do that, that might help us to look in other places for other people that person might have infected. So there's a focus on one hand on trying to identify and shut down chains of transmission, but also to keep that sort of looking out there for where there might be chains that we've missed. And this thing about additional risk-based testing may be warranted, an inadvertent in that sentence, that in should be saying in potentially high-risk groups. So the idea of this is that if in investigating a case and their contacts, there seems to have possibly been transmission in, say, a particular occupational group or a particular workplace, you might want to go and test people who don't actually have a history of contact with anyone you know is infected and who don't have symptoms, but who might seem to possibly be at risk because of that workplace or that occupational group. And this idea of ripples of risk is to do with, if you think of the case as being the pebble in the pond, you start by testing the very close contact people, and depending on what you find there, you might go a bit further out and potentially a bit further out again. So we're trying to shut down chains of transmission, but also give ourselves a chance of finding otherwise undetected cases and chains. Part 3, which is about monitoring trends in diseases with similar symptoms. This monitoring of symptoms under normal circumstances can be a useful way of getting a kind of early warning of when, say, the flu season is about to hit, or if there's something unusual about this season's flu. If you see, so these graphs both have this grey line, which is the historical data, and then they've got this year's rate. And so we always track, this is the Healthline calls, and ILI is influenza-like illness. So that's a cluster of symptoms about cough and fever and so on. Unfortunately, they're not so great for using for an early warning system for COVID-19 for us, for two reasons. One is because we really want to find cases as soon as they appear, and by the time you see a signal on this kind of scale, that would be a lot of cases. But also because, you know, people calling Healthline has got to do with more than just the level of symptoms. So there might not normally be many people calling Healthline in March and April. They might still have a few symptoms, but they know it's probably not a cold and probably not flu, and they don't feel they need advice on it, so they don't call. But in our current context, we had a lot of people calling then, and we had another peak recently. So that's not going to tell us whether COVID's getting going somewhere. And this is sentinel surveillance from general practices. And again, there's a lot goes into whether people attend general practice during a pandemic. That's different from normal. However, keeping an eye on these things and looking regionally might be useful in identifying regions where a closer look is warranted. And the other thing that this kind of surveillance, syndromic surveillance, can be used for when you're trying to eliminate a disease is to just make sure that the testing system itself is working well. So if we want to make sure that people are presenting for testing and therefore we're likely to find the cases, we might look at how things are going compared with normal. Because if people aren't sharing the fact they've got symptoms because for some reason they don't want to be tested, then that would be a worry if we were seeing rates of people reporting symptoms that were much lower than we'd expect. We'd be worried that maybe people aren't coming forward for testing and therefore we might miss cases. Unfortunately, again, in this context, it's not so helpful at the moment. And the reason is because we actually have a lot less symptoms going on. We actually, this is the data from Flu Tracker, which has a huge panel of people who report each week what symptoms they've had. And it kind of shows the benefit of alert level 4 on things more than just COVID transmission. We've actually got a lot lower rates of people with, this is the fever and cough data, than we would normally expect. And this is almost certainly not because people are reluctant to divulge that, because the flu tracking doesn't have any implications. You just let them know what's happening on. So we can't really use the data on what's happening syndromically to tell us really either whether we're seeing an early peak or whether the system is, whether people are coming forward for testing appropriately. But we keep an eye on it because, as I said before, some regional breakdowns might be useful. And also, you want to be keeping your eye on everything, just in case it does provide something that turns out to be really useful. Part 4 of the National Testing Strategy is about the border. And in terms of testing at the border, as we probably all know, people coming into the country and who are in managed facilities are tested now at day 3 and day 12. And the reasons for that timing is to do with trying to catch people who at day 3 who are infectious early, either because they have a relatively short incubation period or they got infected a wee while before they arrived, and then day 12 again to try to pick up people who might have a longer incubation period. The rules for crew are quite complex and change. In fact, at the time the testing strategy was written, they weren't tested unless they were symptomatic. Now they're tested on arrival. And border workers are a focus for testing and encouraging them to have a very low threshold for testing if they have symptoms, because they are potentially at risk. There are other surveillance strategies available to us. One could argue that they're not particularly useful right now for surveillance in New Zealand because, as I said, we don't believe that we have new cases happening. And these are ways of getting a sense of how many people in the population are being infected and have been infected. So serology, I know that James Usher talked about this. There's some research projects going on that are doing serological testing, but it's not being used as a surveillance strategy at this point. And wastewater testing, if we were concerned that if we had transmission in the community and we were wanting to get a general sense of whether the prevalence is going up and down in populations, that can be useful, but again, probably not so useful right now. And I know that some of the regular health surveys that get done have been asking about things like people's adherence to some of those population measures that are one of the pillars of our elimination response. So that is my talk. Thank you.
Thank you, Trish. We have a few questions that are coming in.
Sure.
First of all, can you please comment on the reasons why people leaving isolation can refuse to be tested and the implication of those refusals?
I can't comment on the reasons for that because that would be a legal issue, I imagine. I don't know how many people are in that situation. It's obviously a concern if people are leaving isolation without testing, but I actually don't know any of the details of that, so I'd hesitate to say anything very definitive.
Fair enough. Trish, how does surveillance for COVID-19 differ from surveillance for other epidemics such as the seasonal flu or measles, for example?
Well, in relation to seasonal flu, so the surveillance, it's obviously the surveillance for the COVID has, as I said, it's changed over time and will continue to do so. Surveillance for the usual flu is, there's a couple of key reasons for it. One of them is that sort of early warning system and keeping an eye on rates, in case we've got something unexpected and it starts shooting up. And we need to think what's going on here and respond in some way. Another reason is because the one component of the usual surveillance involves taking swabs of a sample of people who come in with flu-like illness, and that helps us to know what strains are circulating, which in turn can give us some information about how severe we think the season's likely to be for planning, but also feeds into the decision making about the vaccine for the following year. So those things, they're the sort of that's the purpose of the flu surveillance. For the COVID, it's been really around first of all figuring out how much of it's coming into the country, and then obviously trying to track down people who've been infected and shutting down chains of transmission. Then there was a period where we were actively looking for cases that might not be symptomatic in case there was transmission we weren't expecting or hadn't seen. And now, as I say, we're moving more back to trying to identify it when it happens so that we can shut down the chains of transmission. If we may eventually go to something like serological testing, which would look for those sort of bigger picture patterns in the population.
Mm-hmm. Thank you. Waiting for a few more questions to come through. So right. While we do, are there any additional insights you may want to share from your presentation that you didn't get a chance to cover while you were talking? I'll put you on the spot. Sorry about that. But
no, I mean, I think I was really, it feels like a really long time since the end of March. It's actually not that long, but it's been very much an evolving kind of situation. And there's been a lot of trying to, we had plans, and so we didn't start from nothing, but you know, this is a completely, I hate to use the word unprecedented, it's a bit overused, but, you know, we've been responding and working out what we're going to do next sort of all at the same time. And I think actually we've done a pretty remarkable job of doing all those things and coming through as well as we have at this point.
It does seem like an awfully long time ago, doesn't it?
Mm.
One last question for you. Is there anything that you think is missing in New Zealand's surveillance strategy?
You know, you can always come up with something that would be sort of more gold-plated. And, you know, in some other countries where there's actually really high rates of transmission going on right now, there's a whole lot of stuff that people are proposing or doing around, you know, regular swabbing. Like there's a whole discussion going on about students coming back to college in the States and whether they should just be being swabbed every week because you need to find the cases and take them out of circulation quickly. And so all that sort of asymptomatic screening, you know, in that context, it's probably a really good idea. But right now we actually have a very low probability of people being infected. And so I think that what we've got is probably as good as we need for our purposes, given that we don't have endless clinical or lab resources. So doing that very, very detailed kind of precautionary swabbing is, I don't think it's justified at the moment, but you know, if things change, then that might change.
Thank you very much, Associate Professor Patricia Priest.
Thank you.